Hello everyone and welcome to another insightful episode of Azkka Virtue podcast. More alarming is what we don't see. Behind every diagnosed diabetic, there may be 2 or 3 silently progressing towards the same fate. Today, we explore a powerful shift in medicine from treatment in the field of diabetes care. Dr. Subodh Jain from Prayagraj, Uttar Pradesh. He is founder, chairman of Dr. Subodh Jain's Diabetes Care and Research Center.
Way back in 1986, when I was in third year, the seed was sown at that time. Thereafter, by number of people, and this was my vision that this is the future of non-communicable diseases in medicine will be there.
Right.
So cardiovascular, as we were developing, it was written diabetic foot with 2 feet over there.
Okay.
So people were asking, the patients were asking, what is diabetic foot? That is how this was evolved. Regarding your second question, the gaps in patients' care, so since so much long experience I am having, there are a number of gaps, and what I would like to stress, number one gap is patient education.
Very true, so true. What impresses us the most is you were so visionary. More further, the data is really scary is what we see.
So what comes, the diabetic, frankly diabetic patient, young patient, they come to me with, they say ki sahab, reversal is possible because there are so many things on social media going on.
Yeah.
We can reverse it. Of course, partial reversal is possible. It has been shown in number of trials and the research that वो 1 घंटे तो क्या कहें, वो 5 मिनट भी एक्सरसाइज नहीं करते. Screening repeatedly, and in most of the women they develop later on diabetes also, pre-diabetes and diabetes.
Why is pre-diabetes so common in younger non-obese Indians?
As I have enumerated, showing you the cardiometabolic risk. So
Right.
this is actually the dyslipidemia, the hypertension, or the smoking, quitting smoking, quitting alcohol. They all will be there. Once the report comes to 115, 116 glucose, they just ask and they come. And they come, look doctor, I am diabetic now. I say, good news is that you are not diabetic.
Right.
So they are happy. But then immediately I say, but there is one bad news also, that you are going to be diabetic in near 2 or 5 years. In spite of that, they progress to the pre-diabetes and diabetes, frank diabetes, after over a period of 2 years or 3 years, usual. So they say कि सब कुछ किया फिर भी हो गया, तो हमने कहा this was inevitable. So this has happened now. Now you will be requiring medication also.
Right. Hello everyone and welcome to another insightful episode of Azkka Virtue podcast, where we bring science, clinical wisdom and real world healthcare conversations together for doctors, patients and caregivers alike. India is often called the diabetes capital of the world, but what's more alarming is what we don't see. Behind every diagnosed diabetic, there may be 2 or 3 silently progressing towards the same fate. Today, we explore a powerful shift in medicine from treatment to prevention, because the future of diabetes care isn't in managing complications, but in stopping the disease before it begins. And to help us understand this transformation, we have with us a leading expert in the field of diabetes care, Dr. Subodh Jain from Prayagraj, Uttar Pradesh. He is founder, chairman of Dr. Subodh Jain's Diabetes Care and Research Center at Prayagraj. The center is first and exclusive state-of-art center in Uttar Pradesh, which is specializing in evidence-based treatment grounded on 30 plus years of research experience of Dr. Subodh Jain. Welcome to the conversation on the rising era of preventive diabetes. Sir, it is an absolute pleasure to have you joining us for this conversation, because this is something which is very less talked about.
Definitely.
So, thank you so much for sparing time for us and joining for this.
Yeah.
So, sir, I will move right into the first question. Sir, could you briefly share with us, your journey and what inspired you to establish Diabetes Care and Research Center here in Prayagraj? because I'm sure there has to be some motivating factor which has gone behind this. And what gap in diabetes, which you found out, आपको लगा कि ये diabetes care में जहाँ पे थोड़े gaps है, and which you feel that you should fulfill by bringing up this state of the art center.
Definitely, Bhavani, way back in 1986, when I was in third year, MBBS.
Achha.
So what happens, we go to the clinical side. And my first posting was in medicine. And fortunately, the first case allotted me at bedside was of type 2 diabetes. So from there, the seed was sown at that time. And thereafter, of course, my mother was also diabetic. That was year in 1986. Thereafter, I attended the various conferences, and it was shown the International Diabetes Federation's atlases and the datas. They were telling all the doctors attending the conference that it is going to explode.
Right.
Number of people living with diabetes was very, very less.
Right.
And there was prediction that this will explode.
Very true. Very true.
Of course, after doing my undergraduate, I went for PG in medicine. And in medicine also, though I wanted to do DM endo, but somehow due to the circumstances, and at that time in 90s, I did my MD, completed my MD in 1988. Very few people were going for super specialization. The MD medicine was in itself was a big achievement, and you start practicing. So I also started practicing, and endocrinology was not that much. Of course, it was an evolving branch.
Right.
And altogether, the diabetes was also increasing. I was inspired by number of people, and this was my vision, that this is the future of non-communicable diseases in medicine will be there.
Right.
So cardiovascular, as we were developing, and you go by history or you go retrospectively, the people with cardiovascular diseases, non-communicable diseases, they are increasing. So this is the trend all over the world.
Right.
That as you develop, the developing countries, they develop non-communicable, the living standard goes up. So the communicable diseases, though unfortunately malaria, dengue or infectious diseases is still common in our country, but this is, the diabetes has outnumbered.
So true.
And that vision paid me, and I established the only diabetic foot clinic first time in 2005.
Wow.
Way back.
Wow.
So first Indian Diabetic Foot Association conference was there at Kanpur.
Acha.
And all the stalwarts, like I may name Professor Arun Bal. He is still there at Breach Candy, Mumbai. He was there.
Oh.
And the diabetic foot, most of the my patient they came, and my clinic, not at this place, it was different place was there. It was written diabetic foot with 2 feet over there.
Okay.
So people were asking, the patients were asking, what is diabetic foot? Diabetes is
पता
okay,
भी नहीं होगा.
but हमको पता भी नहीं था कि diabetic foot क्या बोला है, ये diabetic foot क्या होता है sir?
So true.
So, and most of the doctors practicing diabetes, they were general practitioners like me, of course. They were not aware of diabetic foot and its complications.
Oh.
So that clinic was established, and here at Association API meeting, we invited Alethea Foster. She was a podiatrist in UK, and she came. And then she देखा उन्होंने कि I am running this foot clinic, and with monofilament I am testing vibration test, and with tuning fork 126 hertz tuning fork. उसने कहा कि oh doctor साहब, you are doing wonderful job, and I was detecting at that time peripheral neuropathy and counseling patients about the diabetic foot.
Wow.
Later on, as the number grown, so this was the whole journey.
Right.
This was then this center was evolved, and you can see that how the way diabetes should be practiced that all the experts, like neurologist, the nephrologist, cardiologist, they are nearby.
Right.
And I am having 3 dietitians with me.
Wow.
And doing all sorts of, so that is how this was evolved. Regarding your second question, the gaps in patient's care, so since so much long experience I am having, there are a number of gaps, and what I would like to stress, number one gap is patient education.
Very true. So true.
The patient, this is a chronic condition in which the diabetes self-management education, what we call it, DSME, if it is not there, you are bound to fail. And this is commonly seen that more than half, more than 50% of your patients, they are not at goal, they are not at target.
Right.
HbA1c7 is rarely you see day-to-day basis. The patient, they come with the report of HbA1c of 8, 9 or 10, and they are never at their goal. The basic gap is education.
Very
so,
true. Very true.
And doctor has got very little time. What to say about endocrinologist?
Right.
They, like me, I am practicing solely diabetes now. Even I don't have time to spend for educating the patients. So the solution is that you must have diabetic educators with you. So at my center, what I would like to suggest the doctors who are saying this, and if you want to do practice of diabetes, you must have enough staff, 2-3 educators with you, 2-3 dietitians with you, the specialized nurses who are able to simply dress or remove callus from the patient's foot and do simple tests. They might be doing this fundoscopy, they might be doing this BPT examination, and all sorts of exams. So they are there and they are helping me a lot. So that pays you a lot. And better patient management is there along with this. This covers all. The dietary education about their diet. क्योंकि कोई भी पेशेंट आता है तो अल्टीमेटली उसका सवाल यही होता है कि साहब खाएं क्या, क्या खाना है मुझको। वो बहुत बड़ा सवाल, आते हुए भी वो यही पूछता है, जाते हुए भी वो यही पूछता है। बाद में वो करे ना करे बात अलग है, लेकिन ही इज सेटिस्फाइड विद दी कि हाँ मेरे को खाने पीने में बताया गया। तो बट imparting dietary education in a right way
is important.
With personalized वो written chart जो आप दे देते हो वो तो they are
वो general
not
होता है
helpful.
वो
In
तो
general they are not helpful, not at all helpful.
Right.
So this was the number one gap. At community level, the use of this social media like this is we are doing here.
Right, absolutely.
We are spreading education and awareness.
Right.
So you educate diabetes management. What I find is nothing but education. Right from the prevention to treatment or treatment of diabetes per se, treatment of glycemia, treatment of hypertension, dyslipidemia, whatever it is, hypothyroidism or cardiovascular disease. Until and unless you properly educate the patient is bound to not to adhere. He will leave the medications.
So true.
Every second patient comes कि साहब वो ठीक हो गया था, सब अच्छा हो गया था, तो मैंने दवा छोड़ दी. You have to stress them in each and every effort for exercising. Exercise prescription schedules, exercise motivational education. So education is such a boring thing, so
but very important for managing
but it is the most important thing. So I will stress on this gap. Then of course there are number of things which we will discuss later on.
Right. आपने जो भी कहा, it is so inspiring. The journey itself is so inspiring. And what impresses us the most is you were so visionary. I mean, at the time while you were studying, somewhere deep down you knew that what the data would look like maybe say 30 years, and when you said it can explode in future, it has actually exploded. And I think a lot more further, the data is really scary is what we see. So having that understanding that how the disease can progress over the next few years, and ensuring that the right care and the setup is given much before it explodes. It itself is very visionary. So, and I think that is one of the reason this state of the art center that you have created, because you have taken care of every single aspect, that it is not only about a patient coming in, आपको मिलेंगे, आप दवाई लिखोगे. It is not about that. It is about the holistic infrastructure that you have created, right from education till treatment and follow-ups. So I think that is indeed, sir, very visionary, and that is the reason why this center is so much talked about in this part of the country. So, sir, now I will get into that. When we talk about diabetes, we often focus on diagnosed cases, which is very, very common. But the real concern lies, in what the expert calls as silent reservoir. These are individuals who are not diabetic yet, but are slowly progressing towards it. So, in your clinical experience, which is more than I think 3 decades now, how large is this silent reservoir of pre-diabetes in a country like us?
So, what happens? The mother comes or the father comes, or both the parents, they are diabetic, they come with their kid, or the son or daughter, they come to clinic, and they are not much worried about their
own health.
But after I have given them prescription and educated them all, the question comes कि मेरे बेटे को तो नहीं डायबिटीज हो जाएगी. That comes, and I just see that the son is overweight. He is not exercising at all. He is busy with the, क्या करें सर, वो कोचिंग में स्कूल पे होते हैं या कॉलेज में होते हैं, फिर उसके बाद कोचिंग है, फिर प्रिपरेशन फॉर एग्जामिनेशन है, और कॉम्पिटिटिव एग्जामिनेशंस दे आर गोइंग फॉर, एंड वो सब टाइम नहीं है, एंड देन सोशल मीडिया एंड मोबाइल एंड व्हाट नॉट, so many things are there, but exercise part is missing.
So true.
Here comes the pre-diabetes. And what we have enough data to show that number of pre-diabetics is much more than the diagnosed case of diabetes. So, so it is 136 million people, they are suffering with, they are having pre-diabetes, while we are having 101 million diagnosed diabetes cases. So it outnumbers the diabetes.
Big time, yeah.
And out of those 136, approximately 60% will be converted into full-blown diabetes within 2 to 5 years.
Oh.
So again there will be explosion,
right,
and this will keep on exploding. The number will be coming, and this is the window of opportunity. What this suggests, that this is the window of opportunity, that here we can, if we apply our preventive strategies properly, we can prevent, not only prevent what comes, the diabetic, frankly diabetic patient, young patient, they come to me with, they say ki sab reversal is possible, because there are so many things on social media going on. We can reverse it. Of course, partial reversal is possible. But at the stage of pre-diabetes, of course, you can totally stop it.
Absolutely.
What is my experience is that you can stop it. You can, just by lifestyle changes. It has been shown in number of trials and the research that they have prevented the 3 major diabetes prevention program. They have stressed that you can actually prevent up to 60% of the patients suffering from pre-diabetes. You can prevent it from becoming their frank diabetic just by lifestyle modification. So I mean, lifestyle comes, it is easy to say but very difficult to practice.
Implement, absolutely.
साहब डाइट में आप पूरा like in controlled studies, randomized control or trials, you have a strict control over the subject. But in real world, you don't have so. So they have shown that Mediterranean diet or whatever diet, healthy diet, I think everybody knows it. But hardly anybody practice it.
Very true.
So you have to see that one should only a little change in diet Like I say, my dietitians, I always say that whatever a person, because habit die hard, and I give an example, if you remove H from habit, habit remains. If you remove A, bit remains. If you remove B, it remains. It never goes.
Wow.
So that is the habit.
Right.
And it's a habit.
Right.
Person has grown up right from childhood, and what we call संस्कार ऐसे हैं, तो वो संस्कार जो उसको मिले हैं, they have created a kind of liking and disliking for a certain food, and every person's food is different.
So true.
So the habits are different. So if you वो habit का change करना बहुत ही मुश्किल है, तो I say remain it as such, जैसे वो खा रहा खाने दो. Make slightest changes, because that will go on a long way.
So that is
will
sustainable.
It will go. It will sustainable.
Right.
Portion size, you can reduce portion size.
Right.
Then you can remove simple carbs. Just give him replacing simple carbs with complex carbs.
Right.
And likings remain there. It should be remain there.
Right.
So that will sustainable, and it works. Definitely, it works.
Absolutely.
So personalize prescription for diet. That is number one thing. Then exercise. We Indians do not exercise.
Right.
If you ask each and every, even patient who are suffering from frank diabetes, they do not exercise enough. So guidelines, they say that 150 minutes of a week you exercise, and 5 days a week you exercise. For Indian guidelines, they say no Sunday, no Monday. Every day, 7 days you have to do not 30 minutes, but you have to for full 1 hour 60 minutes. Then your guidelines have shown. वो 1 घंटे तो क्या कहें, वो 5 मिनट भी एक्सरसाइज नहीं करते. ठीक है. तो और देखा ये गया है कि एक्सरसाइज हम इम्पोज करें पेशेंट के ऊपर कि नहीं, डॉक्टर ने कहा है कि आपको 3 किलोमीटर चलना है रोज. द पुअर पेशेंट्स, देयर आर 3 सेट्स ऑफ पेशेंट. वे कंप्लीटली फॉलो यू. वो पर्सनैलिटी अलग है कि वॉट एवर यू हैव सेड, दैट इज तो they will do everything. Right. They will follow you blindly. Some patients in between.
Partially.
They will follow and they don't follow. And some they don't follow you, whatever you say.
Right.
So these 3 categories of patients, so I go for those who do not want to follow. For motivational interviewing and everything, thing I can do for him, I do. And all my efforts are for those only. And for this poll, whatever they will follow, I know they will follow.
Right.
So, but you have to see the patient's condition. Of course, the knees are gone, osteoarthritis there. You need not to prescribe them. The 3 kilometer chalna hi hai. You can do just by sitting exercise. Then वो सारे तरीके एक्सरसाइज के बताने होते हैं पेशेंट को. लेकिन जो प्रॉब्लम गैप्स वो वहीं पे हैं कि विद इवन ए सिंगल स्टेप, जो कि हम लोगों ने सीखा है, प्रैक्टिकल डायबिटीज ट्रेनिंग की हुई है मैंने, तो वो सीखा हुआ है कि जस्ट आस्क द पेशेंट टू बाय न्यू शूज. वो नए जूते लाएगा तो 4 कदम चलेगा ही. जस्ट आस्क हिम टू गो फॉर दैट मच ऑफ स्क्वायर, जो तुम्हारे घर से छोटा सा चौराहा पहले 50 कदम पे है. यू जस्ट गो देयर एंड कम बैक.
So smaller goals.
So smaller goals, realistic goals you give them, and they will achieve, and then they will get motivation to do such things.
Right.
And exercise में वो भी बहुत ज़रूरी है, what you enjoy. तो मैं तो सबसे पहले यही पूछता हूँ कि क्या करना पसंद करोगे.
Right.
Would you like to dance? Would you like to do yoga? Or would you like to go walking or running or cycling or rowing? Or whatever, football, cricket, and whatever thing, outdoor activity.
Right.
Of course, outdoor activity or indoor exercises also there. हम तो कहते हैं लगा लो अपना टेलीविजन और बिपाशा बसु को देखते हुए करो. क्या करना.
राइट. कुछ करो, लेकिन
कुछ करो, 1 घंटे करो.
That is important.
1 घंटे करो.
Right.
To exercise, most of the patients, they do not exercise. Exercise is the thing. What we are
diet
and exercise. ये है. So
as a lifestyle modification.
As a lifestyle modification, this pays a lot.
Right.
Then there are data that if you lose 5 to 7% of your basic weight, that will prevent. You will be again back from pre-diabetes. So by definition, you go for the criteria, you will be asking me next question.
Right.
Go for it.
So this means जो आपने data का, it is scary. It looks like we are sitting on a ticking time bomb. But at the same time जो आपने कहा कि अगर awareness है तो there are chances of moving out completely. तो अगर हमारे पास awareness है that I can be a pre-diabetic or I am a pre-diabetic and right efforts are taken, जैसे आपने कहा कि you suggest your patient something which can be very sustainable, कि आपको खाना भी कम करना है तो पोर्शन साइज कम करो rather than completely moving out. एक्सरसाइज भी करना है तो स्मॉल गोल्स में शिफ्ट करके उसको अचीव करने का कोशिश करो, तो देन इट विल बी कंटिन्यूड फॉर लॉन्गर टाइम. ऐसा नहीं होगा जैसे 1 जनवरी को होता है कि सारे जिम भर जाते हैं, बट हम लोग अगर 1 फरवरी को जाए तो वापस वो खाली हो जाता है. बट दिस इज समथिंग विच इज़ वेरी सस्टेनेबल एंड आउटकम्स कैन बी रियली एनकरेजिंग बिकॉज ऑफ दैट. सो सर, डू यू थिंक दैट प्री डायबिटीज शुड बी ट्रीटेड एज अ डिजीज एंटिटी इटसेल्फ or primarily only as a risk factor?
No, it should be treated as a disease entity itself.
Okay.
So, because the complications, whatever the pathophysiology is there, it's just like diabetes.
Right.
So, it's a precursor. So, all the pathogenesis mechanism, be it a insulin deficiency, relative insulin deficiency, the decrease in beta cell mass, or increase insulin resistance on the muscle, adipose tissue and the liver level, and the impaired glucagon secretion postprandially, and increased hepatic glucose output,
right,
and the GLP-1 action, the incretin, that is also deranged. So these all, and there are numerous mechanisms has been proposed. They already in action.
Okay.
At this stage only.
Right.
And it has been shown that the macrovascular complications particularly, like cardiovascular or the cerebrovascular and the peripheral arterial disease, the risk of developing this is much more with pre-diabetes.
Oh.
These complications can be prevented if you treat pre-diabetes. So it has to be treated. It's to be taken very seriously. By definition, if you go, there are different definitions. That impaired fasting glucose, that is comes between the 110 and 125. Above 126, you are frank diabetic.
Right.
Below 110, you are normal glycemia. So the term has been, various terms have been given, whether the intermediate hyperglycemia or impaired fasting glucose. Second is the IGT, the impaired glucose tolerance. That means your blood sugar postprandially after 2 hours after the meal or after the 75 grams of glucose, it is between the 140 to 199.
Okay. So that is classified as?
That is classified. Either of them can happen. A person may be suffering from impaired fasting glucose only, or he is showing impaired glucose tolerance only, or maybe having both.
Okay.
And then the HbA1c levels between the 5.7 to 6.4. So 5.7, below 5.7 is normal, and above 6.5 is diabetic. So in between them, this is the pre-diabetes. There can be other criteria should also be included. I am advocating them. In my thought, they should also be included, like that BMI, or BMI has gone now. Only the just waist circumference,
right,
80 and 90 centimeters, male and female.
Right.
Or you can go for the skin fold thickness, subscapular skin fold thickness. These anthropometric data, they suggest.
Okay.
Then just by seeing acanthosis or
the
skin
black
tags,
pigmentation.
They are the markers of the insulin, very high insulin resistance.
Right. Right.
So if you go for them also, again the thin fat Indian phenotype, the visceral fat, if you somehow you can go for that, then liver enzymes you can go.
Right.
It has been shown that gamma GT and ALT, and in some researches they have shown that alkaline phosphatase ALP is also being correlated, high levels than the normal, they are being correlated with development of pre-diabetes.
Achha. Okay.
Then certain kidney parameters. You can go for them. Some say higher urea level, because urea is the end product of protein breakdown.
Right.
They have been associated with the development of prediabetes.
Okay.
So many things. I can further go for FIV score or FibroScan. You can go. So this is all criteria for MASLD, metabolic dysfunction associated liver steatosis. And NASH has been previously associated with development of diabetes.
Acha.
Hypothyroidism, that is also, they call it thyrovigilance. In a patient with hypothyroidism, you should go for screening repeatedly, and in most of the women, they develop later on diabetes also, prediabetes and diabetes.
Right.
Then if you go further, you can go for the dyslipidemia. The Indian diabetes, Indian diabetes score they have developed by Professor B. Mohan Chennai.
Right.
That takes the criteria of age, then your waist circumference, then physical activity, and then this high TG and low HDL. One has to be very vigilant, and then one should diagnose prediabetes accurately, and then go for the treatment also.
So I think this is where, sir, your clinical experience absolutely comes in, that it is not only about the classified criteria, but there are other ways to look at it also. Definitely. And this is where, this 30 years, you have seen thousands of cases, and you can identify that, okay, this can be progressing towards pre-diabetes and, further towards diabetes. So I think, hearing you out, I can only feel that prevention is not optional anymore. It has to be acted upon at as early stage as possible. So, sir, do you believe that current diagnostic markers are sufficient to detect early metabolic risk? And why is pre-diabetes so common in younger, non-obese Indians?
As I have enumerated that all those criteria for diagnosing or screening purpose, others may be they all are showing you the cardiometabolic risk. So this is actually the dyslipidemia, the hypertension, or the smoking, quitting smoking, quitting alcohol. They all will be there, and they show the cardiometabolic risk prevention. Regarding the non-obese younger patients, risk factors, definitely, as I was talking about, that the Indian thin phenotype, developing pre-diabetes and diabetes. The visceral fat is important.
Very common.
So one has to somehow able to delineate the patient, how much visceral fat is there. Its proper measurement should be there. Of course, it can be done by the DEXA. So the cost is definitely there. So it cannot be employed for mass screening purpose. For mass screening, the simple criteria are sufficient. But once you go for treating a patient of pre-diabetes, you must be aware that this fat at wrong places, like perinephric, perihepatic, pericardiac, and that is causing inflammation, and everybody knows that what cascade is going on. The various inflammatory markers like interleukin 6 has been CRP and uric acid, and all those inflammatory markers are there, and they lead to insulin resistance and then the development of pre-diabetes and diabetes. They can also be taken care that you go for CRP, you go for uric acid, you go for IL-6 estimation, or you can go for what they call RBP4. Retinol binding protein 4. This has also been shown to be correlated with the increased metabolic risk. These parameters can also be included or can also be seen apart from the normal diagnosing criteria for pre-diabetes.
So basically that traditional markers may miss early metabolic dysfunction, but I think with your clinical experience over last 3 decades and what you said, can easily, we can catch hold of pre-diabetics very easily. I mean, as what used to be earlier. So, sir, when we zoom out, diabetes is not just a medical issue. It's a public health challenge. What structural changes in healthcare policy are needed from a preventive standpoint, because we have a lot of things in place, policies for managing diabetes, but from preventive point of view, if you can throw some light on that.
As I said, the health education
Hmm.
is of paramount importance,
Hmm.
and that we are lacking. What to say about, I'm sorry to say it, that what to say about health education, education proper is not there.
Very true.
And for decades since we got independence, the education part, particularly in rural areas, it has been absolutely neglected.
Very true. Very true.
Now they are coming up with the newer schools and primary, they are stressing about.
It is so important.
And
School se
so
hi
they
wo
have
education.
incorporated midday meals to just to attract, just to increase the attendance of children for
Right.
primary education. So that has been taken care of in a very few years now, from now. If health education is also being incorporated in that education, basic education,
Absolutely.
that will create a change. अगर मैं अपनी बात करूं तो I have read a quote and I would like to quote it.
Absolutely, please.
महात्मा गांधी ने कहा था, वो कोट मुझको आज भी याद है. इनफैक्ट आई हैव रिटन ओवर माय डेस्क दिस कोट, स्वच्छता ईश्वर का दूसरा स्वरूप है. दिस कोट इज स्टिल इन माय माइंड.
So true.
कि वो कि ठीक है, सो व्हाट यू आर पुअर, दैट डजंट रिक्वायर मनी
Right.
to maintain proper hygiene.
Very true. Very true. It is so important.
And not only the hygiene, this physical hygiene, this mental hygiene also.
Absolutely.
Sada Jivan, Uch Vichar. Here we come for the mental stability, the stress the younger people they are going through.
Going through, yeah. Right from school days, I would
School
say.
days they are going through. So much burden, so much stress is there on it. For younger kids, the education, then reducing mental stress,
Right.
the physical activity.
Increase, yeah.
In my childhood days, I used to have a PT class. Of course, PT class is still there in the curriculum of the day's school program. But that is not
Enough.
actually, no, they don't do physical training. They don't go for PT classes. PT classes, they just
Skip.
go away.
Right.
They don't play. Outdoor games used to be there.
Right.
The interclass competitions for football, cricket and hockey, they were, I was there in all three.
Wow.
So just running from here and there in the playground, then the playground, they have gone.
Very
From
true.
the school premises, they don't have now any playground.
I agree. Very true.
So it has to be there. And thanks to the healthcare policies like prevention, now they have come up with the smart cities and they have their open gyms at every square. You can see, and people are doing it. I am very happy.
Absolutely.
People are doing it.
Absolutely.
The 3 and 4 people, they are waiting for their chance for in a machine or
Yes, very true.
like for early morning you go and every square you will find the people they are doing it. So this is a positive change.
Yeah, emerging. So,
Emerging.
yeah,
This is emerging.
very true.
Like I had to be there way back in 2005 in Bangkok. What I saw, that the road just nearby my hotel, I saw through the window that there was a shop or a small shopping mall was there and parking area was there. As the mall was shut at 10 p.m. night, what the residents they did, they immediately cordoned off the area and they put net and they start playing badminton over there.
Oh.
So this kind of change, utilization of space,
Right.
and they were playing for 1 hour there. So this kind of activities has to be promoted.
Right.
That will prevent.
Small changes, but very impactful.
Very impactful. People, they say that we don't have place here, the roads are busy and how can I go for a walk? How can we play here? We don't have enough space. So one has to create it.
Very true.
If it is not there, one has to create it and one has to do it.
So true. So true.
They has to do it.
Absolutely. There is no option.
No option,
it is
no
to be
option,
done.
not at
Yeah.
all. No option.
Very
For 1 hour exercise daily,
Must.
no option. For everyone. Everyone, whether you are suffering pre-diabetes or you are having not it, you have to physical active, have to physically.
So, even I also read somewhere that, you may have 1,000 problems in your life, but once one health problem comes, then you have only one problem. बाकी फिर कोई नहीं सोचोगे. So why to let that health problem come in when you know that okay, right exercise, good food, can be so good for a long long life and a healthy life, which is important. So basically what I understand is we need awareness programs, routine screenings and policy level interventions.
So policies are there. I was reading it that like Arogya Mandir, they have created 1,50,000 Arogya Mandirs. They have converted these primary health centers into there is a program, national program for prevention and control of non-communicable diseases. It is also already there, is existing there. And they have provided particularly for the diabetes, they have for the care of, and screening I can't say, but they have given the kits for testing blood glucometers, they have given strips are there. And of course, even for ketone bodies, they are testing it. So once you go for, they can also be used for screening purpose also.
Right.
And they are training these ASHAs. ASHA is the accredited social health activists.
Okay.
ASHA means this. So the number of ASHAs are there. They can also include Anganwadi workers. And training and education regarding the screening and screening the population at large who is at risk.
Right. Right.
They can go for it and they can educate. So programs are there, definitely programs are there, but on implementation part, I am afraid it's not there. It's negligible.
So I think steps are being taken.
Yeah. So if we create awareness that this is the problem and this is how we are going to tackle it, then that will work. Definitely that will work.
So true. So I think steps are being taken, but we need to ensure the right implementation which is there. So sir, could you share some real life case since you have been, I think you would have seen thousands of such cases, that how identifying pre-diabetes early truly changed the course of patient's life?
So I would say that the people ask me, or the patient, they ask me that my blood sugar is 112 and may not be. Most of the patient, they have impaired fasting glucose only.
Right.
Because the pathogenesis of both are different. And some they have IGT, the IFG, they outnumber the IGT. So the impaired fasting glucose patient, they it very easy to go fasting and get it done. And most of the patient, they are not able to, most of the people I think, they are not exactly patient. They are not able to do the PPA. So they, once the report comes to 115, 116 glucose, they just ask and they come. And they come, look doctor, I am diabetic now. So I say that I have one good news for you and one bad news for you. The good news, what would you like to hear first? So they say good news. So I say good news is that you are not diabetic.
Right.
So they are happy. But then immediately I say, but there is one bad news also, that you are going to be diabetic in near 2 or 5 years. Right. Because the conversion rate is so high.
So true.
So you are pre-diabetic. So the next question immediately comes, what should I do? So then I go for all these things, and not only a single case, in many cases, I have suggested them all these measures.
Right.
And they have gone through, they have lost 5 to 7% of their weight, and with my dietitian's help, and they have reverted.
Wow.
And even up to the 5 years, 7 years down the line, they are still, they come with the reports and they are being screened, or rather they go for regular testing. Every 6 months or annually they are going for it, the whole profile rather than just fasting or PP.
Right.
And they come with the report and they go happily, sir, मेरे को अभी हुई तो नहीं है, नहीं भाई भाई तेरे को नहीं हुई है, but keep on doing everything.
Yes, you need to be alert all the time.
There is no escape from
Right.
doing exercise and diet.
Right.
You have to do it.
Right.
You have to quit smoking, keep on quitting smoking, never smoke, never drink alcohol.
Right.
So
Right.
there are, I think, not a single case, there are so
Multiple,
many
I'm
cases.
sure,
Multiple
I'm
they
sure.
are there.
But I think that's truly impactful, and as a doctor, I think this would be most satisfying for
Satisfying,
you also.
definitely. That's
At the end of the day, something like this could be managed and rather reversed is something which is very impactful, I would say. So, sir, should screening guidelines be different for Indians considering the phenotype?
Yeah. I have already enumerated that not only the fasting, IFG for fasting, PP and HbA1c, one must include the, of course, anthropometric also, the waist circumference, as Indian Diabetes Risk Score has shown that.
Right.
The family history, of course, the dyslipidemia, particularly the triglyceride and HDL levels.
Right.
They can also be included.
So, sir, customized screening could improve early detection rates. It's about adapting science to population needs, I think. And that is, I think, very, very important. So, sir, finally, the most important question. One that, every viewer would like it to be answered. That if someone is diagnosed with prediabetes, is it a warning or a point of no return? I mean, many people feel it's an inevitable progression, but science suggests otherwise. So, is prediabetes reversible? Because I think you said that it is reversible.
Yeah, it's reversible.
But in your clinical experience, how many number of cases actually can ensure that yes, it can be reversed?
Actually, it all depends.
Which category you are in?
Category you are dealing with. Of course, if you are dealing with the IFG alone, it is. If you are dealing with impaired glucose tolerance alone, it is. Well, the proportion of patients reverting to normal will be much, much higher if the patient is having all the three.
Right.
If he is having impaired fasting, impaired glucose tolerance and impaired HbA1c also. So all the three are there. This shows that he is also not only having insulin deficiency, he is also having all the pathways, all the pathogenic mechanisms which lead to development of pre-diabetes or diabetes. They are there. They are all are working. Then it is difficult to reverse all of them.
Right.
So this is the proper. If person comes only with impaired fasting, he will be reverted definitely, and for a longer period of time, reversal will be there.
Right.
So by these pathogenic mechanisms, you can tell, or you can ascertain that this patient is going to revert and will be sustained in normoglycemia for a longer period of time, and this will go for, in spite of all efforts, and this is clinical practice we see, that in spite of person doing religiously all the things which I have said, in spite of that, they progress to the pre-diabetes and diabetes, frank diabetes, after over a period of 2 years or 3 years, usual. So they say कि सब कुछ किया फिर भी हो गया, तो हमने कहा this was inevitable. So this has happened now. Now you will be requiring medication also.
Right.
So I just write down medicines for treating normoglycemia.
Yes.
So these are the subset of patients which progress, and these are the subset of patients who do not progress.
Right.
A number of heterogeneous factors are there.
Absolutely, that is always there.
Mental stress is there.
True.
Some people, in spite of everything, the body tries to regain weight. Those who have lost it, the hormones, the ghrelin and all those counter hormones, they come up, they increase hunger, they increase.
And now you have everything on your fingertips, delivered at your home. So, yeah. Okay.
So the body tries to remain in that state only, of overweight state only. So once you lose all these natural system, they come up. All the counter-regulatory hormones, they come up. They say, why are you starving? You must have food. So in spite of the low BMR becomes low.
Basal metabolic rate.
As you reduce your weight, the BMR becomes low.
True.
So in spite of eating nothing, you are again,
your body is adapting to
body
that
is adaptive mechanism that comes into play. So most of the people, they are not able to lose weight.
Right. But I think end of the day, what I could get out of the conversation that we had, that yes, pre-diabetes, it is very important, that education is required. If there is education, at every individual level, then maybe you will reach out to the doctors at the right time. And once that is done, it is important that, through the guidance of the doctor, how it can be reversed so that we don't get into, a full-fledged diabetic. And the data, which is very scary and, exploding, maybe to a good extent that can be prevented.
Definitely.
Okay. As we conclude today's discussion, one thing is clear. The future of diabetes care lies not in managing disease, but in preventing it. Prediabetes is not just a medical term, it's a window of opportunity, as what we have understood from the conversation. An opportunity to act early, live better, and avoid complications. And also, don't forget to like, share, and subscribe to the Azkka Virtue podcast, and share it with someone who might really benefit from this knowledge that we have got today. And to our viewers, remember, the best time to act was yesterday. The next best time is today. So stay aware and stay healthy. Sir, thank you so much for joining for this conversation. It was indeed our pleasure. And I'm sure with this conversation that we had, a lot of people and a lot of viewers will benefit out of it. Thank you once again.
I hope so. Thank you.